Hi all, today we will be discussing modes of mechanical ventilation in continuation with our previous discussion on terminologies relating to respiratory mechanics from the patient side and from the ventilator side. So what is a mode? Mode is you deliver a breath to the patient and how you do it is called as a mode, correct? It is as simple as that. So this is a predetermined pattern of patient ventilator interaction to achieve a mechanical breath. And this will be defined by trigger, target and limit, and target is usually either a pressure or a volume. So how to classify different modes? There are three things that is necessary for you to classify a different mode. So one is the control variable. Control variable is your pressure or volume. Second is your breath sequence. Breath sequence is whether the breath achieved is a mandatory breath or a spontaneous breath. Third thing is target schema. So how is the method of breath delivered? How is the flow delivered to the patient to achieve your set control variables or your set targets? So there are set point, dual control, servo control, adaptive, etc. I will be discussing that at the end of presentation. So for you to understand this ventilator naming, you need to know certain terminologies. This we already discussed in the previous class. We will talk about understanding few more about the mechanical ventilation naming or taxonomy, and thereby classifying different modes. We will compare different modes, and finally in the future classes we will discuss about how to use these modes in patient care. A breath is essentially one cycle of positive flow and negative flow put together in terms of a flow time curve. So positive flow is equal to your inspiration, negative flow is your expiration, correct? So start of inspiration to end of inspiration will be your I time, inspiratory time. Your start of expiration to end of expiration, or start of negative flow to end of negative flow will be your expiratory time. If you put both of these together, you have the total cycle time, correct? Total cycle time or total ventilatory period. If you want to demonstrate the same thing in a ratio format, that is your I:E ratio, which is usually at 1:2. A breath is considered as assisted if some or all of the work is done by the ventilator. That is why you essentially put the patient on a ventilator, isn't it? So you want some amount of work to be taken off the patient's load to reduce the work of breathing, especially during inspiration. An unassisted breath, you call something as unassisted if the ventilator is going to only provide support and not determine anything else. It is going to provide flow at the rate which is determined by the patient's inspiratory effort, so that the transrespiratory pressure remains constant. The example is where you provide your baseline pressure PWP throughout the cycle of inspiration and expiration, correct? So the classical example is your CPAP, continuous positive airway pressure, where the airway pressure remains at X amount of pressure set by you both during inspiratory and expiratory cycle. So essentially breaths are classified according to what starts and what stops inspiration. This starting and stopping can be done by either patient or ventilator, and depending upon this you classify them as spontaneous or mandatory. So this is the table where we will be discussing the spectrum of support given by the ventilator to the patient during a breath. This washing machine looking like thing, assume this as ventilator. Okay, I could not find a ventilator short beautiful looking icon. Okay, so if the ventilator is going to trigger, limit and cycle a breath, then that's a mandatory breath. To know what trigger, limit and cycle are, I suggest you go and listen to previous videos or refer to standard articles or textbooks. Assist is where the patient starts, but how much to give and when to end is determined by the ventilator. Support is patient starts and patient ends, but how much to give in between is being determined by the ventilator. Spontaneous is everything is being determined by the patient himself or herself. So mandatory is full ventilator support. I should not use ventilator support, fully ventilator driven. Spontaneous is fully patient driven and patient determined, whereas assist is only start is done by the patient, support, start and end are determined by the patient. So your spontaneous breath is where patient has control over timing, and start and end are determined by the patient. So triggering and cycling are done by the patient. A spontaneous breath can be assisted or unassisted. A mandatory breath is where patient does not have any control over the inspiratory time, and it is done by the ventilator irrespective of patient's efforts. All mandatory breaths are hence assisted. The advantages and disadvantages of mandatory modes are these. See, in a mandatory mode, you have a guaranteed respiratory rate and a guaranteed tidal volume. So, a minute ventilation, which is the multiplication of tidal volume into respiratory rate, is guaranteed. If minute volume is guaranteed, it means you have complete control over your carbon dioxide removal. So, in conditions where you require complete control over your carbon dioxide levels in blood, you will use a mandatory mode. A classical example is raised ICP conditions, raised intracranial pressure conditions. The another situation where you will prefer a mandatory mode over a spontaneous mode is where the patient's system is not working according to patient's needs. In fact, it is working opposite to what is required. In asthma, you want the patient to have a longer exhalation time so that the carbon dioxide washes out of the patient's respiratory system. It is trapped in asthma, isn't it so? But what happens in a patient who is breathing spontaneously? They breathe fast. So during this fast breathing, expiratory time is reduced and carbon dioxide still stays trapped inside. In ARDS, again, you want the patient to take a low tidal volume breath, but you have no way of doing that if the patient is breathing spontaneously. Another situation where mandatory mode might be used is where no work of breathing is essential, as in a controlled setting like an operation theatre. Disadvantages are it is not comfortable for the patient. So there is higher chances of asynchrony. So you have to provide higher sedation and requirement for paralysis. Continuous use of mandatory mode results in deconditioning of both patient's respiratory drive and respiratory muscles. Respiratory drive decides to go for a vacation because something else is doing the work and it is not willing to come back from the vacation when you want it to. Similarly, respiratory muscles decide something else is doing the work instead of me, so they do not want to work when you want the respiratory muscles to work. Essentially, weaning becomes very difficult if the patient is put on mandatory mode for a long time. Is spontaneous mode that good? So, do we go for spontaneous mode for all patients? It is again not so. See, even though it is comfortable, it has better ventilation and hemodynamics, you do not have a guarantee for minute ventilation. Okay, so minute ventilation is not that well controlled by you. Plus, there is the extra chance of auto triggering that can happen. Auto triggering is where some non-respiratory factor triggers the ventilator to give a breath to the patient when the patient is not wanting a breath. Okay, so auto triggering can happen when there is fluid in the circuit, when there are secretions in the ET tube. I think all of us must have come across this situation, isn't it so? So in these situations, instead of setting a flow trigger, you can set a pressure trigger. So that might help to some extent. No guarantee for minute ventilation means you cannot use a spontaneous mode where a patient has a diminished or an unreliable respiratory drive. So if you want to control respiratory rate, this will be the wrong choice for patients. A ventilator works on the principle of this equation of motion. Okay. So this works under the assumption that patient makes no respiratory effort and there is no auto trapping or auto air trapping, auto PWP. So if in this equation of motion you have set pressure as the control, meaning you are setting a specific pressure to the patient, this becomes the independent variable irrespective of the respiratory mechanics. So what becomes the dependent variable? The dependent variable will be your volume and flow. What will it vary depending upon your compliance and resistance? On the other hand, if you want to keep a volume controlled mode of ventilation for the patient, volume control is essentially again flow, isn't it so? So both of them will be predetermined. If these are predetermined, your pressure becomes the dependent variable here. It depends on the changes on compliance and resistance of the patient. Okay. So pressure varies based upon compliance and resistance of the patient. So K is your baseline value or PEEP value. Pressure controlled versus volume controlled. Pressure controlled has the advantages of avoiding excess inflating pressure because essentially you are setting the pressure. So there is no risk of or lesser risk of barotrauma. You can provide an increased mean airway pressure. This results in better alveolar recruitment and better ventilation perfusion matching. Volume control has the advantage of maintaining minute ventilation and tidal volume, and plus during inspiratory hold you will exactly know what is happening to the respiratory mechanics in the patient by changes in your PIP waveforms. Waveforms we will discuss in next class. Disadvantage is your tidal volume varies based upon compliance and resistance, correct? So there is chance of volutrauma, plus you will not know what is happening inside the patient. Volume control disadvantages are if the time constants are varying between the alveolar units. If it's a heterogeneous disease the lung is suffering from, then there might be poor recruitment. The ventilator might deliver a higher PIP to compensate for that, to achieve the set tidal volume. That can result in increased risk of barotrauma and asynchrony. Okay. So between pressure controlled and volume controlled, which is better will depend upon the patient's pathology and the pediatrician behind the ventilator. So if you put the control modes that we discussed now with the terminologies that we discussed earlier, a volume control mode will have the assist control as trigger, where control is your ventilator, assist is the patient. Okay. So the ventilator trigger is time. So you have set the patient to receive 1 breath per 5 seconds. So that is your control mode or your ventilator triggered breath. If the patient triggers a breath within this 5 seconds, the patient will be assisted by being provided adequate pressure or adequate volume, whichever control you have set, and given breath for that particular amount of time that you have set. So that will come to our next point, where the inspiratory time cannot be altered by the patient in a controlled mode of ventilation. TI is being set by you. So if the patient is only on control mode, imagine. So every 5 seconds patient will receive breath irrespective of patient's efforts. If you have added this assist mode, then after a breath the ventilator waits for some time. Is the patient going to trigger? Is the patient going to trigger? If the patient is triggering, then the ventilator will provide a breath. If the patient is not triggering, then the ventilator will provide a mandatory breath. The spontaneous breath or a patient triggered breath is identified by you by looking at this negative deflection in the waveform. The target set in a volume control mode is flow, it is not volume. The cycle variable will be the volume. After the patient has achieved a set amount of tidal volume, then the inspiration cycles down to expiration. Pressure controlled ventilation is where the target is pressure. The cycling is done by time. So you set your PIP and time. Again, your inspiratory time cannot be altered by the patient. A pressure support ventilation is where the trigger is done only by the patient. So only if the patient has a good respiratory drive, you can put the patient on a pressure support ventilation. The target will be pressure, and what determines the end of inspiration will be flow. If the flow is 25% of the initial value, then the ventilator cycles down the inspiration and the patient takes a expiration. So here in pressure support ventilation, initiation is done by the patient, and similarly time is not set and varies from breath to breath determined by the patient. So as a consequence, your flow waveform, your tidal volume, your inspiratory time will vary depending upon the patient's effort and respiratory characteristics. If you want to put all of this together in a single tabular column, this is it. A control mode of ventilation, assist control will be the trigger, whereas pressure support ventilation is where trigger is only by the patient. The target is pressure in pressure control or pressure support ventilation, and the target is flow. The method of delivery is flow in a volume controlled ventilation. Cycling is done by volume in volume control, time in pressure control, and flow in pressure support ventilation. So this is about control modes. What about breath sequences, the second part? So there are 3 breath sequences that can be done: continuous mandatory, intermittent mandatory, and continuous spontaneous. If you want me to put it very simply, mandatory mode is where both start or stop of inspiration is being determined by the ventilator. Spontaneous mode is where start and stop is determined by the patient. Okay. So, if ventilator determines either start or stop, it becomes a mandatory breath. If patient determines both start and stop, it becomes a spontaneous breath. Then what is this continuous and intermittent? Continuous is where no spontaneous breaths are allowed between mandatory breaths, whereas in intermittent mandatory ventilation, spontaneous breaths are allowed. Continuous spontaneous ventilation is where there are no mandatory breaths and all are spontaneous. So, if you put this control mode and breath sequences together, this is your classification of ventilator mode. Continuous mandatory ventilation or intermittent mandatory ventilation can be a volume control or a pressure controlled mode, whereas a continuous spontaneous ventilation is only pressure control. This is otherwise called as pressure support ventilation. All of you must have seen this in your ventilators, isn't it so? Usually it is given at the end of choosing modes, correct? So, yeah, pressure controlled spontaneous ventilation is your pressure support ventilation. There is something else called as synchronized intermittent mandatory ventilation. It is intermittent mandatory ventilation. Only thing is there is a small window of opportunity around each breath where the ventilator waits for the patient to initiate or patient to try to initiate a breath. I should say like that. If the patient is making an effort, then the ventilator will give a mandatory breath. Note that this is not a patient triggered breath, this is a mandatory breath. Okay. Basically the mandatory breath will try to synchronize with patient's inspiratory efforts, so that it offers better comfort to the patient and better synchrony between the patient and the ventilator. So, this top one is a assist control mode where mandatory breaths are given. In between there is a negative deflection, means patient has triggered, then the ventilator will give the target set by you and the ventilator will limit the breath. So, the target, your cycling and your time is being determined by the ventilator. In SIMV mode, here synchronized intermittent mandatory ventilation, this is a mandatory breath. Why? Because there is no negative deflection. Here there is a negative deflection and patient has taken a breath in between two mandatory breaths. Did you see that? So, this is a intermittent mandatory mode. I will put it like that. Let us not put it at SIMV. This is a intermittent mandatory ventilation. What is synchronized intermittent mandatory ventilation? Synchronized is where this is a mandatory breath, correct? So, there is a time period. Okay, so this is when the ventilator is supposed to give the next mandatory breath. So, there is a time window around this, and if the patient is making an effort as evidenced by this negative effort, negative deflection, then the ventilator provides a mandatory breath. Can you see this waveform and this waveform are similar, means both are mandatory breaths. Only thing is this mandatory breath is synchronized with the patient's efforts. Got my point? In between you see there are two breaths that are triggered by the patient. Okay, so the patient has triggered the breath, patient has taken a breath, it is supported by pressure. Can you see that? It is supported by pressure here, and the patient determines the end of inspiration. So, the patient determines the start and end of inspiration, and in between if you have added pressure support, that breath will be given extra additional pressure support. Okay, the timing is different. See, between this breath and this spontaneous breath, the timing is different. So, basically in assist control, if you see, even if the patient triggers a breath, the timing is not determined by the patient but by the ventilator. Whereas in SIMV, if the patient has triggered a breath, the patient can determine the timing also. Okay. Whereas if the breath is by the synchronization window or the assist window, then the timing, everything will be similar to that of a mandatory breath. So, that is your synchronized mandatory breath. So, that is again the concept of trigger window and synchronization window. Trigger window is patient triggered breaths. Synchronization window is the mandatory breath is synchronized with patient's efforts. This is again an example of a synchronization window, which is at the end of expiration and at the end of inspiration. And last but not the least, coming to target schema. set point is your standard pressure control and volume control in your conventional mode. Dual targeting is where both pressure control and volume control can be there in a single breath. Suppose you have set up volume control mode. Patient takes a very good effort, then the ventilator can switch from volume control to pressure control mid breath. That is dual targeting. Servo target schema is where servo is any device that amplifies a signal. Here the patient signal is amplified to provide a proportional level of assist to the patient. The example of a servo is automated tube compensation. See, anything in the line of patient receiving a breath, for example the ET tube, means the patient has to work extra to overcome the resistance of the tubing, isn't it so? So more work of breathing by the patient is required. So if you add this option to your conventional mode, the ventilator takes over this additional work of breathing. This is not a mode per se, but just an add-on. Another example of a servo target schema is proportional assist ventilation. Here in proportion to the patient's efforts, airway pressure will be adjusted. So more effort by the patient, more pressure, less effort by the patient, less pressure. So it changes according to patient's efforts and lung dynamics. Target schema, another example of your proportional or proportional support or your servo mode is your NAVA, neurally adjusted ventilatory assist, where the electrical activity of the diaphragm are detected, and even before the patient tries to take a breath, the electrical activity will be detected and the ventilator will synchronize better with the patient's effort to take a breath. So basically the patient ventilator synchrony improves. Adaptive targeting scheme is where the example of pressure regulated volume control mode comes in. Pressure regulated volume control is where the pressure varies depending upon the compliance of the lung to achieve the target volume. Suppose the patient's compliance was very poor to start with. The ventilator had to provide too much pressure, okay, to achieve this set target volume. As the days progressed, the compliance increased because the underlying pathology improved. Then for delivering the same amount of target volume, less amount of pressure will be required. So you need not stand by the ventilator to see what has happened to the compliance and change the pressure. The ventilator will do the work for you. Optimal targeting scheme is where the ventilator determines the optimal values for achieving a minute volume based upon the parameters that you input into the ventilator, like the weight, height, etc. So these are all examples of target schema. There are few other target schema like intelligent. There is something that you need to understand called as closed loop target schema. So I am not touching about those things because it will become too very long. Okay, and I don't think all of you will sit through that. So thank you for listening to me patiently. I would like to thank Dr. Deepak from Rainbow Children's Hospital for helping me refine this presentation and put it across to you in a simple format. So thank you, sir, for your help. So these are my references. You can go ahead and go through these articles and textbooks. Thank you for listening to me patiently. Please subscribe and hit the notification icon so you get instant notifications whenever I post a video. Share this among your colleagues, juniors, seniors, your academic group, so we can all learn pediatrics together. Bye bye.